Hi, this is Herb Kressel, editor of Radiology, and welcome to the September 2016 Radiology podcast. This month we have two provocative discussions for you. First, our senior deputy editor, Dr. Deborah Levine, will be speaking with Dr. Manisha Bal, who, with her colleagues from Duke University, authored an interesting study on the impact of breast density notification on radiologists' reporting practices of breast density. This is a multi-state study. Then, Dr. David Kalmus, deputy editor for Neuroradiology, will be speaking with Dr. Philip Kickengerder, who, with colleagues from the University of Heidelberg, reported on radiomic profiling of glioblastoma as identified an imaging predictor for survival stratification. There's a lot of interest these days in radiomics to further enhance our understanding of diagnosis and prognosis, and I think you'll find both the manuscript and the discussion quite stimulating. As always, we look forward to your comments and hope you enjoy the September podcast.
Hi, I'm Debbie Levine. I'm the Senior Deputy Editor for Radiology, and I'm here today with Dr. Manisha Bal. Hi, Manisha.
Hello.
She is a radiologist, a breast radiologist at Massachusetts General Hospital here in Boston, and she's here today talking about a study that's going to be published in the September issue of Radiology about the impact of breast density notification legislation on radiologists' reporting practices in breast density. So welcome, Manisha.
Thank you.
Can you tell us a little bit about what you did and what you found?
Sure. Well, the purpose of our study was to evaluate the impact of breast density notification legislation on breast density reporting by radiologists nationally. In 2009, Connecticut became the first state to enact a law, and since then, more than 25 states have passed notification laws. There have been several theories about the impact of these laws on reporting practices by radiologists. That is, would radiologists upgrade their breast density assessments in response to these laws, or would they downgrade them? So to answer that question, we used data from the National Mammography Database and found that immediately after the laws were passed, there was a small but statistically significant decrease in the reporting of dense breasts by radiologists. However, within 10 months after the legislation had passed, the percentage of mammograms reported as dense returned to pre-legislation levels. And this suggests that the notification laws don't have a long-term impact on reporting practices.
Wonderful. And how did you get access to this database?
The National Mammography Database is a voluntary registry that's maintained by the American College of Radiology. And during my fourth year of residency at Duke University Medical Center, I had the opportunity to spend some time at the ACR as an AMIS fellow in quality and safety. And while I was there, I learned about the registries and met many staff members who work at the ACR, and through that fellowship was able to get access to the database.
Wonderful. Now, when I read your paper, one of my first questions was, well, how representative is this database of mammography done in the United States? And you later said it was about 2% of the mammograms were being reported to this database. So how representative do you think those are of the national practice of breast imaging?
Our study included an analysis of about 4 million mammograms total, but as you said, that's a small percentage of the total mammograms that are performed every year. The ACR maintains the National Mammography Database, which is a voluntary registry, and so not all facilities are required to report their data. I do know that the ACR provides benchmarking data and information for quality improvement to the facilities that do report. So I think those facilities that are reporting are interested in getting those sorts of quality metrics. But it isn't necessarily representative of all breast imaging facilities nationwide.
So it might be that these particular practices have more of an interest in knowing how they compare and how they're performing?
I think so.
Yeah. One other question I had is, you looked at like time zero and looked 20 months backwards and then 10 months forward. And figure 2, I think in your paper, and hopefully our video production people can put figure 2 here, but I happen to have it here in our studio. It, to me, looks like these different practice patterns start diverging about 15 months before the law is enacted. But you talk about time zero, comparing before and after. And I know from our own legislative process here in Massachusetts, for more than a year ahead of time, we were talking about it, wondering what to do, getting the letters ready. You would imagine that it would influence practice before the law is actually passed. What do you think about that, the fact that maybe it started earlier than what you're saying in your paper?
I agree with you. I think there was a lot of anticipation prior to the laws. For example, if a law is being enacted on January 1st of 2014, I think those facilities were aware of the law, the imminent passage of the law, and may have started changing their practices even before the start date. So I do think that because breast imagers and other radiologists were aware of the laws, it started changing their behavior, whether subconsciously or consciously, prior to the day of enactment.
Yeah. Okay, terrific. And then you found that in academic institutions, you didn't see the same statistical difference as you did when you looked at private practice. Why do you think that is?
Well, I think that one of the reasons for the downgrade, or one possible explanation, is that there was a fear that so many women would be seeking supplemental screening after becoming aware that their breasts are dense, that it would overwhelm facilities that didn't have the staff and infrastructure to provide high-volume supplemental screening, particularly with ultrasound, which is fairly time-consuming. And I think it's possible that because academic facilities tend to be larger, there wasn't as much of a concern that their resources would be overwhelmed by that, and perhaps that didn't influence that didn't affect the change in reporting as much as other facilities that might have been smaller and more concerned about the staff and infrastructure limitations.
So that's assuming that it's a conscious decision to change the way that you characterize breast density. You mentioned before maybe there's a subconscious component as well. What do you think about that with the timing?
Yeah, I think they're probably both, subconscious and conscious factors at play here when radiologists were thinking about these laws and anticipating their enactment. There's so many factors that go into play, whether it's, reducing patient confusion, medical malpractice, the infrastructure of the facilities. I think there are, many variables that were playing into the decision making regarding density.
And were you surprised by any of the results in your study?
We had, when we were conceptualizing this project, we had anticipated that there might be a slight downgrade in terms of the breast density assessments. Prior to the enactment of the laws, there wasn't really any consequence based on the density assessment that was given by the radiologist, which is a relatively subjective assessment. I hadn't really anticipated that the reporting practices would resume pre-legislation levels pretty quickly thereafter.
Well, it's a wonderful project. It's very interesting. I'm very glad that you and your group did it. What are you working on now?
Well, I recently joined the faculty at Mass General Hospital, and there's a lot of exciting research in breast imaging being done there. I'm currently working on a collaborative research project with MIT on machine learning and how that can help us improve patient outcomes.
Well, I definitely wish you the best, and hopefully we'll see more of your work here in our journal, Radiology.
Thank you.
Hello and welcome to this month's podcast. Today we're talking about the paper entitled Radiomic Profiling of Glioblastoma Identifies an Imaging Predictor for Survival Stratification with Improved Performance over Established Clinical and Radiological Risk Models. And for this podcast, I'm joined by the author, Philip Kickengerder, a resident in radiology from the University of Heidelberg. Welcome, Philip.
Hi, thanks for having me. It's a great pleasure to be here.
So many of our readers may not know exactly what is meant by radiomics. Can you very briefly give us a primer in what radiomics is?
Sure. So radiomics is basically a data-driven approach where you try to extract large amount of quantitative imaging features from a certain tissue of interest, for example, from a tumor, as it was performed in our study from patients with glioblastoma. And those imaging features are then subjected to machine learning methods, which is basically artificial intelligence and based on sophisticated computer algorithms to create certain prediction models. For example, prediction models that tell you how long a certain patient may survive or how likely a certain patient will respond to a specific therapy. So the overall hypothesis behind radiomics is that the imaging phenotype may capture relevant biological information, and you can use the imaging phenotype to predict this biological information. So
in the context of radiomics, can you tell us, in your study, what did you do and what were your major findings?
Sure. So we studied a set of 119 patients with newly diagnosed glioblastoma, and we looked at the preoperative MRI scans. And what we did was to extract roughly more than 12,000 quantitative imaging parameters related to the intensity, to the shape, and to the texture of the tumor. And we only looked at contrast-enhancing T1 and FLAIR images, and we extracted those imaging parameters from the enhancing and non-enhancing part of the tumor. And we then used machine learning algorithms. Specifically, we used the so-called supervised principal component analysis to identify and select those imaging features that are related to the overall and progression-free survival of those patients. And this analysis identified 11 radiomic features that were significantly related to those outcomes. And those 11 imaging features were then used to create the final radiomic signature. And we saw that this radiomic signature nicely separated patients into a low and high risk group for both progression-free and overall survival. And all this was done in a training set with 2/3 of patients, and we separately validated our findings in the remaining 1/3 of patients. And in the next step, we were interested how the performance of our radiomic signature is compared to established clinical or radiological risk models. For example, a clinical risk model may include the Karnofsky performance score or the patient's age, whereas a radiological risk model may include the apparent diffusion coefficient or the relative cerebral blood volume of the tumor. And we all know that both ADC and RCBB value are also related to the patient's prognosis. And what we saw was that our radiomic signature performed substantially better than all those other models that we evaluated. So both the clinical model, the radiological model, or also if we combined the information from the clinical and the radiological model, this was still worse than the performance that we obtained with our radiomic signature. So in the end, we were quite confident that this radiomic signature captures relevant information regarding the prognosis of the patient. So this was briefly what we've done in our study.
So what were some of these 11 features that you identified?
So if you look at, for example, we listed all those features in table 1 of our study, and we listed all those features and related those features to their relative importance score, so their relative contribution to the final radiomic signature. And if you look at the first line, you see the gray level co-occurrence matrix and the energy of the gray level co-occurrence matrix. When we took the standard deviation of this parameter, this was basically the most relevant parameter for the final radiomic signature. When we extracted this parameter from the FLAIR images from the contrast enhancing part of the tumor. So basically this parameter may tell you how heterogeneous the texture, so how heterogeneous the tumor is. And the more heterogeneous the tumor is, the worse the outcome for the patient will be. So a higher heterogeneity of the tumor will be related to a worse outcome for the patient. So this was the most important parameter in our study, for example. Yeah.
So is it typical with radiomic features to be able to have a physiological correlate, that they make sense? Or is it something like, well, the machine found it, so we trust it?
Well, yeah, that's the important point. Of course, we try to think when we have a radiomic feature that is most important, we try to think, what does it actually mean when we look at the picture? Can we identify this radiomic feature when we just look at the picture? But often it is the case that we don't really have an imaging correlate, so we can't really visualize this radiomic feature when we look at the pictures itself. So usually right now, more or less, we trust what the machine tells us, and we use appropriate statistical methods to ensure that the results that we get are correct results. So, for example, we ensure that the false positives, so if we have such a large number of parameters, we have to ensure that the number of false positive parameters is properly controlled, and we, for example, use statistical methods to ensure that the final parameters that are selected and that are found to be significant are really important features. But not always is it the case that those parameters that we identify, that we really can tell, okay, this imaging feature that was identified, we can see it on the picture. This is unfortunately not always the case right now, yeah.
So how generalizable are findings from a single center machine learning study?
Yeah, sure. So what we did was to use a training set and a separate validation set to basically ensure that our findings can be reproduced. The problem that we have to deal with is that when we look at a single center study, we have standardized MRI protocol, we have the same parameters for all the patients. And if we now would go to a different center and try to validate our findings, maybe we would have to deal with different sequence protocols and with different MRI machines. So right now we are not really sure whether we can translate exactly those findings to different centers. However, what we did, for example, was to perform intensity normalization of our MRI data. So this basically allows us to more or less generalize our results. But we haven't done it yet. We haven't done multi-center validation yet, but this will be a critical next step to validate our findings, of course, yeah.
So given that you use contrast-enhanced T1 and FLAIR, it would seem that retrospective data from multiple centers could be used in your model?
Of course, this could be used in our model, yeah, sure, yeah. This would be basically the only requirements, so contrast-enhanced T1 and FLAIR images, and then we could basically validate our findings if we would have those data from other centers as well, yeah.
In the meantime, how are you implementing your radiomics paradigm clinically?
Well, ideally, the process would be if we would be able to send the MRI data directly from the MRI machine to our radiomic pipeline, and the radiomic pipeline would then analyze the data, and in the end you would get a report which tells you, for example, how likely a certain patient will respond to a specific therapy. But before you could do that, you would have to have quite a large number of patients to train your machine learning algorithms, and for each question you wanna address, you have to train a new machine learning algorithm. For example, if you want to predict the treatment response to bevacizumab therapy in patients with recurrent glioblastoma, you have to have a set of patients who were treated with bevacizumab, and you have to run all those patients through the machine learning algorithm, so the algorithm learns how a patient with a good response will look like before treatment, how a patient with a bad response will look like before treatment. So the critical issue is that you have to have a large number of patients to obtain reliable results. But after you would have done this, you could basically send a new patient into the radiomic pipeline, and the radiomic pipeline will tell you how likely this patient will respond based on information it has obtained from the previous patients where it was trained on. So this will be this would be the ideal procedure how everything would work.
So when you're a resident, and at the end of your career, do you envision that radiologists won't be involved in interpreting these images? Will we just show them to a machine?
Well, hopefully not, because otherwise it would be the wrong decision that I went into radiology. But hopefully it will be a tool that helps us to improve decision-making in daily clinical practice, and that supports us in daily clinical practice by extracting more information from the images that we can extract right now. So this would be the ideal situation how this would work, in my opinion.
Sounds good. I'm just curious, are you going into neuroradiology?
Right now, yes. Yeah, that's my plan. Yeah.
Nice. I'm sure the field will be better off for having you in it. So this has been really a fascinating discussion. Is there anything that we haven't talked about that you want to share with our viewers today?
Well, I think there are already quite interesting studies outside the central nervous system. We have studies available already that have been published, for example, from patients with lung cancer, head and neck cancer. So we are also interested whether we can translate our findings to tumors outside the central nervous system. We are currently looking, for example, at prostate cancer, whether we can predict the Gleason score. We're looking at breast cancer patients, whether we can differentiate benign from malignant lesions on MRI. And what also is important, I think, is to relate the findings that we can obtain from radiomics with molecular parameters. And that's what we're also going into right now. We're studying whether we can predict certain molecular parameters from radiomic parameters that we extracting in patients, for example, with glioblastoma, and whether we can use radiomic features to predict certain molecular parameters. So this would also be, I think, interesting to study with radiomics.
Well, sounds good. Well, thank you, Dr. Kickengrader. Thank you for your support of radiology, and we look forward to more great papers from your group.
Yeah, thank you.